So I think the first thing I would say is skeptic is strong, but I am somebody who wants to make sure that there is informed and detailed information for people so that they can make a good decision for themselves. So sooner is not automatically better for a couple of reasons. There are a few biases that are in screening that can actually lead you astray when you're sort of using your personal observation. So the first one of those is called a lead time bias. So what it means is if screening works at all, you're going to advance your date of diagnosis. But the problem with that is that doesn't necessarily mean that you've impacted the time of death at all in any way. That's sort of a separate question, a separate calculation with a separate denominator. And so what can happen is when we look at things like survival instead of deaths from cancer, it can actually give us the wrong answer qualitatively. So something can appear to be a benefit that is actually not helping at all or even harming people. The second reason is there's another bias that's called length bias sampling. We call that stacking the deck. And what it means is that when you screen for cancers, because you're applying it over a period of time, like annually, for example, slow-growing cancers get sort of preferentially detected by the screening test, whereas really aggressive, fast-growing cancers, they go too fast for you to be able to catch them. And so what happens then is we screen. What you see with your personal observations is that the people who get screened tend to do better, and that makes you want to screen more. But the problem with that is you really don't know if it's the screening that's helping, in terms of that whole cascade of screening plus treatment. Are you really benefiting that person, or is what you're doing just sort of picking out the cancers that were already going to do better anyway? What are the potential benefits of that test? And those are usually pretty easy to know, right? We usually are caring about things like reductions in morbidity from the cancer itself or from any associated treatments, or obviously deaths. There's other benefits that people sometimes put in their studies, such as the stage it was diagnosed at. Those start to get to be a little squishier because they aren't things that people actually feel or impact them directly. They're what's called sort of an intermediate or a surrogate outcome. So journalists should really be trying to say, well, what was the outcome? What were we looking at? What did we show a positive effect on? And then really importantly, not just that, because that's where the conversation ends a lot of the time, the other side of it is, did anything unfortunate, adverse, bad happen as a result of that screening test? Because again, screening is not just the test itself. It's not just that x-ray or that blood test. It's a package of activities. If it's going to benefit you, you have to have a biopsy after that, and then you have to have some kind of treatment. So that's the whole package that allows you to benefit. That same package, sort of bad things can happen along the way, and it's important for us to ask questions about what do we know about that, if anything? Did that study look at it? Do we have more information about what happens? It's also helpful to know when you're talking about screening tests, how many people get this disease generally? Do we know, is it a common condition? Is it an uncommon condition? Because when you're screening, what you're doing is looking at a large group of people, the way we do it right now at least. We're looking at a large group of people to try to identify those who have the condition. The problem is most people don't have the condition. And if you don't have the condition and you're not destined to get that condition, you can't benefit from that intervention. You can only be harmed. Here in the US, one potential sticking point with that is that you have to have a system. If what you're doing is saying, in part why we're screening these people so that we can collect information to learn more about them, you sort of need an organized system that is set up to collect that information. And if you don't have that, you're not going to be learning a lot. The plural of anecdote is not data. So if you're one doctor's office who's just sort of doing case reports about what they found from their cancer screening, that's not going to generally advance knowledge terribly far. If you are an organized healthcare system and you're sort of tracking what people are doing in terms of screening, I don't think that in itself is sufficient reason to expose people to an intervention if you don't know if it has benefits to begin with. If it's something that has been established in certain groups and you sit down and you have a discussion with someone and they decide they want to undergo that screening and you want to follow them to see what the sort of natural history of their condition is and how they do, that can be useful ancillary research. I will say that the best way to determine if a screening test is really effective is to do a randomized controlled trial that ends up looking at what happens to health outcomes at the end.